Thanks, Ray, for recording. We've also got Zenel and Hassan who'll be continuing with the presentation as well. As it's a small group, please feel free to turn your cameras on. There's only 3 of you, so we can sort of make this a bit more interactive, and you guys can have the opportunity to ask questions, and we can make it a bit more sort of personal. But also let me know if you're in a place where you can speak freely, and if not, just use the chat function as well, because there will be questions during this talk. Okay, so conditions that we're going to cover from the core conditions list will be adenomyosis. We'll be looking at the various sort of gynecological cancers. We'll also do some things on ectopic pregnancy, endometriosis, fibroids, HPV related to cervical cancer, menopause, miscarriages, ovarian pathology like cysts, a bit on pelvic inflammatory disease, and PCOS as well. For breast, we'll be covering all the core conditions on the curriculum map. However, again, additionally, these are the core presentations that we'll be covering from the curriculum map. Things that we won't be covering, so probably encourage you to go over these in your own time, will be vaginismus, and then the following core presentations will be precocious puberty, subfertility, urinary incontinence, which will be covered in the urology talk, vaginal discharge, which will be covered in the GUM talk, and then contraception counselling, which will be covered separately as well in talks not today. So getting started on gynecology. So this is how sort of the talk today has been split up into sort of menstrual related pathologies, cervical, uterine, ovarian, and others as well. So I'll be talking about menstrual pathologies and cervical pathologies, and then Zenel and Hassan will take over for the rest of it. So menstrual disorders, the normal menstrual cycle. So as with all pathologies, it's important to get an understanding of what's normal. Now, again, if this is something that you've sort of heard before, just shout out, and I want this to be as useful for you guys as possible. It's just a recap of normal menstruation. It's split up into 2 phases: the follicular phase, which is the first 14 days of a regular 28-day cycle, and then the luteal phase, which is the last 14 days of a 28-day cycle. So the follicular phase starts with GnRH being released from the hypothalamus. That stimulates the release of FSH, and as FSH rises, it stimulates development of ovarian follicles. And at some point, the sort of dominant follicle, which is the one that sort of matures first, it's called the Graafian follicle, it produces estrogen, and that inhibits the growth of the other follicles as well. So one follicle turns into the dominant follicle. Estrogen then has negative feedback on FSH and the LH rise, and it also causes the cervical mucus to become thinner, if sort of allowing more easy access for sperm, and it also causes endometrial thickening as well, and division of cells in the endometrium. Estrogen levels then become high enough to cause an LH SIR via positive feedback, and this happens at day 12, and approximately day 12, and this surge causes the rupture of the follicle, and it releases the egg into sort of the peritoneal cavity, where it's all swept by the fimbriae into the fallopian tubes. In the luteal phase, then the Graafian follicle becomes a corpus luteum, so it's in the ovary, which then produces progesterone, which has a negative feedback, decreases LH and FSH, and it maintains the endometrial lining. If the egg is fertilized, then the blastocyst release HCG, which maintains the corpus luteum, maintains the secretion of progesterone, which maintains the endometrial lining further. However, if it's not fertilized, there's no such HCG release, and the corpus luteum then degenerates. Reduced progesterone then leads to degeneration of the endometrial lining, and menstruation occurs. So that was just a brief recap. So possible sort of issues with the menstrual cycle: dysmenorrhea, so painful periods. This can be primary, where there's no underlying pelvic pathology, and usually with primary dysmenorrhea, there are changes related to the pain starts at the start of menstruation. Whereas with secondary dysmenorrhea, which is associated with underlying pelvic pathology, the pain tends to start a few days before the start of menstruation, and this can have various different causes, which will be covered in later sections of this talk. Oligomenorrhea, which is where you have irregular periods, so the definition is more than 35 days between periods or less than 9 periods a year. Again, this can have various causes, for example, extremes of reproductive age, polycystic ovarian syndrome, physiological stress, and various drugs as well, including hormonal contraceptives. And then lastly, amenorrhea, so the absence of periods. Now, again, this can be primary or secondary. Primary is defined as sort of when your periods don't start in the first place. So absence of menarche past age of 13 if there's no other signs of puberty, or past age of 15 if signs of puberty have already started to develop. And then secondary, so when someone has already started getting their periods and then suddenly they stop for a period of over 6 months, or 3 to 6 months, depending on if they're regular to begin with or irregular to begin with. So regular, the period is about 3 months. If they're irregular, it's about 6 months. Again, stop me at any point if anything I'm saying isn't clear. So primary amenorrhea, we can split it up into there's different ways we can think about this. Hypogonadotrophic reasons, so the gonadotrophins, which are released by the hypothalamus and the pituitary, there's a decrease in the levels of them, and that's leading to the hypogonadism. And this can be either constitutional, so that's the most common cause, and a way to sort of check that if a sort of child is developing, so do hand and wrist x-rays is quite an important investigation. Other things can include excessive stress, physiological stress, either from chronic health conditions, chronic inflammatory states, or excessive diet or exercise. Important to consider celiac disease as well, causing sort of, I guess, malnutrition, and that leading to a state of physiological stress. You also have damage to the hypothalamus pituitary from radiotherapy or even trauma, and then endocrine causes as well, so growth hormone deficiency, hypothyroidism, Cushing's, and hyperprolactinemia. And Coleman syndrome as well, which is sort of a rare cause of primary amenorrhea that comes up. You won't see it that much in practice, but it comes up a lot in exams. And this is in this condition, there is a failure of neurons to migrate from the hypothalamus, of GnRH secreting neurons. And so this leads to a lack of GnRH and a subsequent lack of FSH and LH from the pituitary. And again, the exam tick point for this is anosmia, which is where you have a lack of sense of smell, because those same neurons also migrate down to the olfactory bulb. And if they're not migrating, you don't have a sense of smell. Hypergonadotrophic hypogonadism, this is when there's an issue with the gonads themselves. This can either be due to damage to the gonads directly, for example, surgery, radiotherapy, or trauma, or Turner syndrome, again, is the exam favorite, which is characterized by the karyotype XO. And along with sort of many other things, it leads to something called street gonads, which is where the ovaries are sort of replaced by this fiber of fatty tissue, and they're not really functional. Structural causes, so an imperforate hymen, transverse vaginal septa, so structural issues related to the fact that either the menstrual blood can't leave the uterus. FGM, sadly, can also be a cause of primary amenorrhea. And vaginal agenesis, which is where the ovaries and the uterus are formed and intact, but there's an issue with the development of other structures, and so patients don't experience primary amenorrhea. And there's also the causes, congenital adrenal hyperplasia, which is where you have deficiency of this enzyme 21-alpha hydroxylase, and this basically leads to a decrease in the production of corticosteroids and mineralocorticoids, and an increase in the production of androgens by the adrenal glands, because the hormones that aren't being produced, sort of, you have more hormones being sent into this other pathway that produces lots of androgens. And then lastly, androgen sensitivity syndrome, which is again just a rare cause. Secondary amenorrhea. So various different causes. This is when a person has had periods and then suddenly stops. So the most common one is pregnancy or breastfeeding. Really important to rule that out. someone's presenting with secondary amenorrhea, the first thing you should probably be doing is a pregnancy test. And then depending on age or other symptoms, menopause or premature ovarian failure, which we'll talk about later in this talk. Functional hypothalamic amenorrhea, so this is related to physiological stress, increased exercise or diet. Hyperprolactinemia, because this inhibits the release of GnRH. Hypothyroidism, so someone's hypothyroid, their hypothalamus is going to try and upregulate that hormonal axis and increase the release of thyroid stimulating hormone and thyrotropin releasing hormone from the hypothalamus. However, an increase of that results in a decreased release of GnRH, and that's what causes the secondary amenorrhea. And then similar things that we spoke about before: pituitary failure, structural uterine abnormalities. For example, something like Asherman syndrome, which is where it's a complication of procedures to the uterus, for example, either surgical sort of terminations of pregnancy or surgical management of miscarriages or other procedures, and it leads to these adhesions forming within the uterus that then sort of impede the flow of blood. Damage to the ovaries, and then certain drugs as well, specifically things like antipsychotics and antiemetics, because they block dopamine, and they can lead to a hyperprolactinemia, which can then have a knock-on effect. So I don't know if these slides are made available to you afterwards, but this is just another way of thinking about it anatomically rather than primary and secondary. And again, it's just what sort of makes more sense for you. So you can feel free to have a look at this later. We'll be talking about PCOS and premature ovarian failure later. So here we have our first SBA. Feel free. Okay, we've got a poll. Lovely. So please have a read and put in your answers in the poll. Okay, so 50-50 split between option A and B. So having a look at this question, 50-year-old woman has visited her GP with an 8-week history of unbearable hot flushes and vaginal dryness. So the sort of thing we're thinking in our mind here is a menopause. This lady is of the sort of expected age, and the symptoms as well. Past medical history of hypothyroidism, eczema. It's regularly levothyroxine and has the Mirena intrauterine system. What's the most appropriate additional treatment to initiate for this patient? So this question is testing how well you know the treatments for menopause. And the answer is actually E. So we'll talk about this in more detail later, but treatments for menopause, you can have combined hormonal replacement therapy, or which is estrogen and progesterone, or sort of non-combined if a patient already has something like a Mirena in place or is already, for example, on a progesterone-only pill for contraception or for any other reason. So in this particular patient, she's already got the Mirena, so she's got the progesterone component, so she only needs estrogen replacement. Menopause, so we can think of menopause in different stages. For example, premenopause, which is where it's before the hormonal changes start. And initially, there is actually an increase in FSH because the body is trying to sort of compensate and try and like recruit more follicles. However, during this period, this might lead to sort of like irregular menstrual bleeding. And there's perimenopause, which is sort of fluctuations 1 to 2 years before menopause starts. And then you've got actual menopause where the menstrual cycles start, and then postmenopause, which is a year since the last period. So the cause of menopause is the fact that you basically run out of follicles, and all the follicles aren't active and aren't producing estrogen. And this sort of decrease in estrogen production leads to the symptoms of menopause. Average age is about 51. However, 10% sort of can have them a bit earlier. And this timing is related to different factors like genetics, so there might be a family history, or environmental factors, so for example, smoking, and things like that. In terms of symptoms of menopause, so 80% of women usually experience symptoms. However, 25% have symptoms, a quarter of you have symptoms that are sort of severe enough to require treatment or require them to present. The most common one is menstrual irregularity. So periods either become longer or shorter, and this can continue for up to 4 years. Actually, interestingly, increased bleeding is also common. Additionally, sort of vasomotor symptoms, hot flushes, night sweats, headaches, and this is also more common at night, and also when people have increased stress as well. And this can then lead to things like sleeping difficulties, which can cause issues with memory, cognition, brain fog, mood as well. So mood changes are quite common, and also urogenital symptoms as well. So atrophic vaginitis, because normally what estrogen does is keep the vaginal walls well lubricated. A decrease in estrogen leads to a dryness in the walls, to put it plainly, and this can lead to dyspareunia, so pain on sex, recurrent UTIs, and also incontinence as well. And actually, it's urge incontinence that's most commonly reported, rather than stress incontinence. And additionally, decreased estrogen can lead to loss of libido as well. So in terms of investigations, one important thing to note, that not only are the sort of reported symptoms of menopause important to consider, but also the associated risks. So because you've got a decreased estrogen, is acts as a bone protection, as it inhibits osteoclast activity. And so if you've got a decrease in estrogen, increased risk of things like osteoporosis, so decreasing bone mineral density, and other things like cardiovascular disease and dementia as well. So in treating menopause, you're not only treating the symptoms, but you're also reducing the risk of these other associated diseases or conditions. In terms of the diagnosis, it's a clinical diagnosis if women over 45 years old, but if women are under 45 years old, specifically under 40 with menopause symptoms, you should do an FSH as well to see if to exclude something specific like premature ovarian insufficiency. You also do other things to rule out other causes of amenorrhea if it's clinically indicated: thyroid function, blood glucose, cholesterol. It's a check for risk factors for ischemic heart disease. However, usually it's a clinical diagnosis. Now, in terms of the management, as with everything, we can split this up into conservative, medical, and other things as well. So in terms of conservative and lifestyle measures, things like increasing exercise, improving sleep hygiene, so sort of sleeping in a cool environment, avoiding excess alcohol and caffeine, and trying to reduce stress. You can also use psychological interventions, so CBT or mindfulness, which are various sort of relaxation techniques. And although we're not really taught a lot about it, lots of patients find that herbal remedies can also be beneficial as well. Just an interesting point. As well as, so when we look at the medical interventions, we can have hormone replacement therapy, which we'll talk about in the next slide, and then non-hormone replacement therapy. And so for non-hormone replacement therapy, techniques or things that we can give are SSRIs or SNRIs, so fluoxetine or something like venlafaxine, and gabapentin and clonidine, and these are especially good for the vasomotor and the mood symptoms as well for the SSRIs and the SNRIs. However, so clonidine, for example, has quite a few side effects that may sort of limit its use. For example, like drowsiness, dry mouth, constipation, and I think it affects the blood pressure as well. And then, as well as treating the actual symptoms, it's important to focus on the patient holistically and think about reducing risk of associated conditions we spoke about before, so specifically osteoporosis, things like encouraging people to stop smoking, calcium, vitamin D replacement, weight-bearing exercises, considering bisphosphonates as well. And actually, HRT can have a decrease the risk of ischemic heart disease and dementia as well, as I said before. So hormone replacement therapy, it's good for vasomotor symptoms, mood swings, sleep disturbances, and urogenital symptoms, and it also helps with the osteoporosis as well. You can have multiple types available: oral, as a pill, or transdermal, like a patch. And the most important thing to consider here is the fact that we're giving estrogen for symptomatic relief. However, if you give someone unopposed estrogen, can anyone tell me what sort of the risks of that are? And if you're really stuck, it's written on the board. If you can't speak, just let me know in the chat. Okay, someone said breast cancer, VTE. These are all risks of HRT, definitely, but specifically estrogen. Actually, before, probably best just to establish this, have the three of you done gynae yet? Have you done Mod B? Yeah, so MS has said endometrial cancer. Thank you, Claudia. Thanks, Angel. Okay. So yeah, thank you for letting me know. That's helpful, so I know how to sort of tailor it, and I won't ask questions that you may not have come across. So yeah, it's endometrial cancer. So estrogen and progesterone both have different effects on the endometrial lining. Progesterone maintains the thickness, whereas estrogen promotes the growth of and the division of endometrial cells. And so, as anything that increases the rate of division, that increases the risk of cancer. And so, if you're giving someone estrogen, they're at increased risk of endometrial cancer. A way to counteract that or deal with that is to give a progesterone component, and that's why it's called combined HRT. And the progesterone component can either be given as an oral tablet, so combined with the estrogen, or as a Mirena, which is an intrauterine system. It's similar to the copper coil. It's like a slightly smaller device, and it sits in the uterus, and it secretes local progesterone. So it acts locally to decrease the effect of the estrogen. Does that make sense? Let me know if that doesn't, because this is a really important concept to understand when thinking about HRT. Okay. So on the next slide, I'll talk a bit more about the types of how you'd approach the type of HRT that someone needs, but just briefly, some risks associated with HRT. There's a slight increased risk in VTE because you're giving someone estrogen. However, that's only with oral. So you can get, if someone's at particularly increased risk of VTE, you can give them a patch, because a transdermal estrogen doesn't really increase the risk. A slight increase in stroke. However, again, this is oral only, and slight increase in coronary heart disease as well. There's an increased risk of breast cancer as well. However, interesting, the risk of dying from breast cancer isn't raised. And there's also risk of ovarian cancer as well for all HRTs. Now, when sort of counselling patients about the risks, it's important to think about it from a risk of benefit analysis and looking at the time that the patient's exposed to that risk, the effect or the current effect on their quality of life of the symptoms of menopause. I think it's often not spoken about a lot, but this sort of symptoms can be really detrimental to patients' quality of life. And actually, the risks it's important to talk about them, but it's a relative thing as well. So contraindications, so reasons that you definitely wouldn't offer someone HRT: current or past breast cancer due to the increased risk, any estrogen sensitive cancers, undiagnosed vaginal bleeding, or endometrial hyperplasia. And this is just because if you give someone HRT, that a side effect can be vaginal bleeding. For the first 3 months, it's sort of expected or not surprising. However, if someone's already got vaginal bleeding and you don't know the cause, as we'll talk about later today, one of the things that could be causing that is endometrial cancer. And so you don't want to mask any effect or clinically sort of get confused with someone's symptoms and what's causing them. It's now related to the VTE and stroke and coronary heart disease risk. If someone's got uncontrolled hypertension or history of VTE or acute coronary syndrome, you don't want to give it to them either. Generally, it's used for sort of 5 to, well, it says here 2 to 5, about 5 to 10 years. And with a sort of regular follow-up, patients can expect results in their symptoms after about 3 months. And they're followed up regularly, and the aim is to sort of wean them off them after this amount of time has passed. So it's most useful between the ages of 50 and 60. After that, the risks of things like VTE, stroke, and coronary heart disease start to become a bit greater because of patients' age as well. Okay, so in terms of choosing the correct formulation, if someone's got local or systemic symptoms, if they've got local symptoms, they can use a topical cream. So you can get estrogen creams or like vaginal lubricant jellies, which can be quite useful. So they've got systemic symptoms there, you're going to have to give them something that's a systemic treatment. Secondly, do they have a uterus? If they don't have a uterus, then there's no increased risk of endometrial cancer because there's no endometrial lining. So you can give them estrogen only HRT. However, if they do have a uterus, then you need to give them estrogen and progesterone either in the form of Mirena or a pill. And then thirdly, have they had a period in the last 12 months? So if they have, then you can give them. So this is all quite special stuff. It's just good to have an awareness of it, but no one's going to sort of quiz you on the technicalities of it. But if they have had a period in the last 12 months, then you want to give them cyclical HRT. Which basically just means it's on a sort of monthly cycle, and they do sort of have a bleed. If they haven't, then you can give them continuous HRT. And again, the reason for this is the fact that if someone has HRT can cause vaginal bleeding, and this is sort of more likely if it's continuous, because you're not allowing a gap for someone to be able to bleed. And so if it sort of this decreases the incidence of, I guess, of like investigating people for vaginal bleeding, because wanting to exclude things like endometrial cancer or other pathologies, and you don't want to it helps with addressing things like that. And if that doesn't make sense, just sort of pause me or put something in the chat and I can explain that further. And then lastly, contraception. So if they are less than 50-year-olds, they require contraception for up to 2 years after their last period. If they're greater than 50 years old, then they require contraception for 12 months. And this again can be in the form, if they've only got a Mirena coil in, so progesterone releasing intrauterine system, then that can act as the contraception as well. Okay, so that we've talked about menopause. Now I'll talk a bit about premature ovarian insufficiency. And this is essentially sort of early menopause or the onset of menopause symptoms before the age of 40, and that's the cutoff. It can have various causes, but it's caused by the fact the ovaries stop ovulating and producing estrogen and progesterone. It can be idiopathic. Often patients with idiopathic POI may have a family history of it. It can be primary, so they can be autoimmune conditions targeting the ovaries. We can have FSH receptor abnormalities, Turner syndrome, or something called Fragile X syndrome as well, which is an X-linked dominant. It's caused by an X-linked dominant mutation. But again, it's slightly rarer, and this will come up more in peds. And then secondary causes are iatrogenic. So if you've had an operation to remove the ovaries, if you've had radio or chemotherapy to the ovaries, or infections as well. So mumps and TB can damage the ovaries. Symptoms, it's the same symptoms as menopause. However, I think more of a concern would be the effects on fertility, especially as these women are younger, and this is sort of more of a concern. However, it's important to appreciate that some women can still conceive, as the ovarian function can return spontaneously. Like with menopause, there's an increased risk of osteoporosis and cardiovascular disease. However, this is an increased risk because whereas in menopause you have a sort of relative reduction in estrogen, progesterone, in POI you're absolutely not producing estrogen, and so the risk is a bit higher, and that's another really important reason that patients get treatment for this. In terms of investigations, you can diagnose POI if someone's got a persistently raised FSH. So the persistent is the fact that it's over a period of time. So you have to have 2 tests 4 to 6 weeks apart. And other investigations that might be done are hormonal tests, so looking at the LH, FSH, progesterone, estrogen, testosterone. AMH levels as well can be an indicator of like follicle count. Other things you can test are steroid cell antibodies, so if it's an autoimmune cause, thyroid function, prolactin, and a pregnancy test as well, if someone's presenting with amenorrhea. They can also do ultrasounds, transvaginal ultrasounds, to directly look at the ovaries and look to see if there's any follicles there. So in terms of management, similar to menopause, conservative treatments would be things like smoking cessation, advice on bone health, counselling, and also addressing the fertility aspect as well, so potentially referring for IVF or fertility treatments. And then medical management, giving HRT till patients are about 51 years old to decrease the risk of these other complications. And traditional HRT is preferred to giving someone back-to-back combined oral contraceptive pill, just because of the components of the different types of estrogen and progesterone that are in HRT. I think it has better profile on the blood pressure as well. Importantly, if it's important to counsel on contraception as well if the patient doesn't want to conceive, as there is still a risk of conception. So that's sort of issues with the menstrual cycle. We'll move on to cervical disorders, but pause me if anyone has any questions on this topic. No? Okay, we'll move on then. So we've got another SBA. Okay, we've got two answers. Okay, we'll end the poll there. So the answer to this question is just testing if you know the risks for cervical cancer. So you've got a 33-year-old woman who's had a routine cervical smear demonstrating high-grade dyskaryosis, which is a type of CIN, so cervical intraepithelial neoplasia. Use the combined pill for 3 years, with a smoking history, which factors most likely significantly increase her risk of developing cervical cancer. The answer to this question was B, HPV subtype 16. So I think we're running a bit short on time, so I'll go through this a bit more briefly than I did the previous section. So cervical cancer, there's sort of a bimodal age distribution. Peak diagnosis is in the sort of late 20s, so 25 to 29, and then there's a second peak in the 80s as well. Usual type is squamous cell carcinoma. And in terms of the risk factors, so one of the most significant risk factors, as well as smoking, is HPV infection, and specifically HPV subtype 16, 18, and 33. HPV is a human papillomavirus. It's a type of virus that I think so now we have vaccination against it, and so incidences of cervical cancer caused by HPV are decreasing. However, what the virus does, it infects the cervical epithelial cells and causes different changes to the genomes of those cells, and that increases the risk of cancer. Important to understand that although lots of people are infected with HPV infection doesn't automatically lead to cancer, as most people can clear the virus. However, in the portion of people that don't clear the virus, it can increase the risk of cancer developing. Other risk factors include using the combined pill for over 8 years. However, this risk decreases if people stop using the pill for after that period. And immunodeficiency and other STIs as well. Clinical features: vaginal bleeding is one of the most common. Or actually, sorry, the most common is asymptomatic. So people are picked up on the smear test. Other things can be vaginal bleeding either after sex, in between periods, or postmenopausal bleeding, dyspareunia, so pain during sex, changes of vaginal discharge, pelvic pain, and B symptoms as well. So in terms of examination, so if someone's presenting with symptoms that are making you worried about cervical cancer, you should do a speculum examination, so looking for bleeding, discharge, and abnormal lesions. If that's abnormal, that patient needs an urgent referral to colposcopy. And you can also do a bimanual and a GI examination as well. In terms of investigations, it's just only good to do an STI test, chlamydia test, STI test including chlamydia. And the main investigation of diagnosis is something called a colposcopy, which is where it's a day sort of investigation. Patients go to a clinic, usually in a hospital, and they use a speculum and they use a camera to visualize the cervix directly. And then they can stain the cervix with different stains to identify abnormal areas. And actually at colposcopy, if they see an abnormal area, they can cut it out or take a biopsy of it. And then after colposcopy, various imaging as well. There's the FIGO staging for cervical cancer. I don't think it's super important for you guys to know the details of this. Just be aware that there is a staging system, and like the severity determines how it's treated. Right. So this question is testing your knowledge of the cervical smear testing program. So if you could pop your answers in, we'll give about 20 seconds as we are running a bit short on time. Okay, yes, you might have seen the answers to this. The answer to this is the repeat the smear test in 1 year. This is a patient who's had a previous smear test with HPV negative, cytology normal, most recent one showing HPV positive, and it's asking you what the appropriate next step is, which is to repeat it in a year. And I'll explain why on this next slide. So cervical screening, it screens women and transgender men 3 yearly between the ages of 25 and 49, and 5 yearly between the ages of 50 and 64. After this age, patients can request to be screened if they haven't had a sort of a recent smear test. They take a sample of around the cervix using sort of a Brushing's brush, and they test it for the presence of high-risk HPV, so the strains 16, 18, and 33. If the test comes back negative to HPV, then that patient's sent back to routine recall. If the test comes back positive for this high-risk strain of HPV, then they test the cytology, so they actually look at the cells. If looking for changes or abnormal changes in the cells. If cytology is negative, then they rescreen in a year time and just see if that person has managed to clear the virus. If they have, then that's fine. They can be sent to routine recall. If they haven't managed to clear the virus, then they retest them in another year time. And then if a year after that they still have the virus, then they just send them to colposcopy anyway. If, however, they do find abnormal cells, they refer them straight to colposcopy, because then you want to get a proper sample of the cells to look at under the microscope. Important exceptions, so if a patient has HIV, then they're tested annually because they're immunocompromised, they might struggle to clear the virus. And then smears are delayed for 3 months if a patient's postpartum, if they've had a miscarriage or a termination. So treatments for cervical cancer, again, this is just depending on the stage. So if it's local, they can do a local incision called a LETS, or something like a cone biopsy. If it's sort of extending more, they can do surgery, so a radical hysterectomy, and then depending on the size, with or without chemoradiation. However, if it's sort of spread beyond the uterus or spread to other pelvic organs, then it's quite difficult to remove it all surgically. So the first point would be chemoradiation, and then if it's quite severe, then you might be thinking about palliative care. So we've got another question here. Have a look and let me know what you think the answers are. Okay, we'll end the poll. So this is a 20-year-old woman with postcoital bleeding, so bleeding after sex. There's no discharge or abdominal pain, currently using the combined pill, and reports some episodes of bleeding. On speculum examination, you can see a red tissue around the cervical os, which is the opening of the cervix. Most likely diagnosis here is a cervical ectropion, and I'll explain why. So an ectropium is where, so in order to understand what this is, you kind of need to have an understanding of the anatomy of the cervix and the cell types in the cervix. So this is the uterus. This is the cervix, which is sort of the neck of the uterus, and the different types of cells. And the inner lining of the cervix, we have the endocervix, which has a different type of epithelium to the external lining, which is the ectocervix. And there's a transformation zone between the ectocervix and the endocervix. And sometimes the cells from the inside can sort of proliferate and extend outwards to the ectocervix. And this is where we get something called an ectropium. So it's a large area of the columnar epithelium of the endocervix that's sort of extended past the transformation zone. And this is visible on a speculum. So if you were to do a speculum examination, you could see this is what the cervix looks like on examination. Here there's no ectropium, whereas here you can see sort of a red ring. It looks a bit velvety, and that's the ectropium. It can be asymptomatic, however, it can lead to discharge or bleeding. And treatment is only really required if the symptoms are causing the patient discomfort. So you can stop the causative factors. There's certain risk factors. So the main risk factor is increase in estrogen, either from pregnancy, during adolescence, and starting puberty anyway, or the combined oral contraceptive pill. So stopping reversible risk factors, if that's not possible and it's sort of really causing bothersome symptoms, you can do cryotherapy or ablate the columnar epithelium. But this is a benign condition. And then lastly, for this section is talking briefly about cervical polyps. This is what they look like through the speculum. They're benign growths due to hyperplasia of the columnar epithelium of the endocervix. So contrary to ectropions, though, there's a small risk of malignant transformation with these. Peak incidence is 50 to 60 years, more common in women who have had multiple, or patients who have had multiple pregnancies. Various different proposed theories about why they're caused, either chronic inflammation, abnormal response to estrogen, or localized sort of congestion of the cervical vasculature. They can be asymptomatic, they can cause troublesome bleeding and discharge, and if they're quite large, they can lead to infertility, but that's rare. In terms of investigation, you need histology to diagnose, and because of the small risk of malignant transformation, you want to get a sample. You'd also do triple swabs for infection, and a smear as well to rule out CIN or HPV, high-risk HPV infection. If they're small, they can be removed in primary care. If they're large, they can do sort of diathermy and remove them via loop excision in the colonoscopy clinic or under general anaesthesia, depending on how large they are. Okay, so that's the end of my section. If you could provide feedback for that section, that'd be greatly appreciated. And once you've done that, we'll move on to the next part of the talk.
Great, thank you, Shivani, for that. Should I share my screen now?
I'll stop sharing.
Thank you.
That's all right. Thanks very much. Bye, guys.
Take it. So I'll share my screen and we'll start the second section, which is going to be uterine and ovarian disorders. Great. So we'll start with the uterine disorders, which are very high yield, and we can start with an SBA. So I can launch. We'll just wait for one more answer. Perfect. I'll end the poll there. So this SPA is describing a 35-year-old African lady presenting with a 6-month history of menorrhagia, abdominal cramps, and increased urinary frequency. We notice her uterus is irregular and enlarged. So what other symptoms do we think she has? So to answer this question, first, we need to understand what condition is going on. So with this SBA stem, they've given the ethnicity of the lady as African. So in a gynecological setting, that leads us to think they could possibly be talking about fibroids. And we confirm this with the symptoms. So menorrhagia is something we commonly see with fibroids, as is cramps and increased urinary frequency. And the pelvic examination is also in keeping with that. So the answer was, in fact, constipation. And we'll go through why that's the case. So what are fibroids? Fibroids are benign smooth muscle tumors of the uterus, and their continual growth is likely stimulated by estrogen production. So there's 3 types of fibroids. The most common type is an intramural fibroid. So this is one which is confined within the muscle layer of the uterus. The second type is submucosal. And these are the slightly problematic ones because these develop immediately under the endometrium and can protrude into the uterine cavity. And so what this means is it can actually distort the shape of the uterine cavity, and as a result can have effects on fertility and can prevent patients from having IUDs or IUSs inserted. The third type is subserosal, and this is when, as you can see in this picture, when the fibroid protrudes into the serosal, which is the outer surface of the uterus, and it could also be pedunculated, which means it has a stalk attached to it, just like you can see in the image below. What are some risk factors? So ethnicity is an important one, which the SBA stem tried to get at. It's more common in Black women. In fact, 50% of Black women develop a fibroid compared to 20% of white women. So in SBAs where they are showing common situations, that's often a giveaway. Other risk factors can include family history, increasing age, early start of periods, and obesity. And what symptoms can someone with a fibroid present with? So mostly they are asymptomatic, but when symptoms arise, the most common symptom is heavy menstrual bleeding. And remember, in an OSCE situation, when you're quantifying heavy menstrual bleeding, there's no hard and fast rule. And commonly it's heavy in comparison to what the patient usually reports their bleeding to be. So it's a very individualistic approach. Also, less commonly, there can be pressure symptoms, and that's what the SBA stem tried to get at. Pressure symptoms is when the size of the fibroid almost has an effect on the surrounding structures. So that can include the bladder, causing increased urinary frequency by applying pressure to the bladder. It can also be constipation by applying pressure to the bowel and therefore preventing the passing of stool. And we talked about subfertility already. What investigations do you want to do? So with fibroids, when you have heavy menstrual bleeding, what you worry about most is an iron deficiency anemia developing. And the symptoms from that could be shortness of breath on exertion, chest pain, dizziness, palpitations, and we'd want to test for that so we can prevent anemia developing. Otherwise, testing for the fibroid itself is commonly transvaginal ultrasound, or if that's not possible, transabdominal ultrasound. How do we manage it? Because most patients tend to be asymptomatic, the most common management is just an annual follow-up to just monitor the size and growth of the fibroid. But if there are symptoms, medical management's indicated. So if a patient has a fibroid and heavy menstrual bleeding and the uterine cavity is not distorted, it would be a good opportunity to use a Mirena IUS, because that can help with the symptoms of heavy bleeding very effectively, and it can also act as contraception. When patients don't want an IUS, maybe tranexamic acid can help with the amount of bleeding, and methylamic acid can help with the abdominal cramps. Otherwise, there are other hormonal contraceptives that can be used, such as the combined pill or a progesterone-only pill. Surgical management is the next stage, and often we want surgical management that's fertility preserving, especially if menopause hasn't been reached yet. In this case, you do a myomectomy. As it sounds, it's just removal of muscle tissue. And this can be done abdominally, laparoscopically, or hysteroscopically. And the reason this preserves fertility is because you're only removing the section that has the fibroid. You're not doing a gross removal. Other surgical management options can be ablation of the endometrial tissue, total hysterectomy, in which they remove the whole uterus, or when they embolize the uterine arteries that are supplying blood to the uterus. There's a note here that GnRH agonists can be, if the fibroid's too big, you can use these agonists to shut off the HPA axis. And this will, because fibroids are estrogen dependent, this will reduce the fibroid size preoperatively to make the operation easier. A somewhat niche SBA situation is this red degeneration. So often in the second trimester of pregnancy, because of increased estrogen levels, sometimes the fibroid can grow beyond its blood supply supporting it. So as a result, hemorrhage and necrosis happens in this rapidly growing fibroid. Patients normally present with tachycardia and tachypnea because of the acute pain they're experiencing, and they can also have a low-grade fever. But the management of this tends to be supportive. We can move on to the next SBA, and this is considering a second very high yield condition in gynecology. I'm going to start the poll. I'll stop the poll when I get 2 answers. Great, I've got 2 answers. I will end 3 answers. Brilliant. I'll end the poll there. So in fact, the correct answer in this case was E. So in this case, this SBA, a 30-year-old lady is referred to the gynae clinic. She's had painful periods as a teenager and had the IUS until 2 years ago. Since the removal of her IUS, she's had difficulty conceiving, along with menorrhagia and pain on urination defecation. A diagnostic laparoscopy confirms endometriosis. Which symptom would be in keeping? So in this case, the answer is secondary dysmenorrhea. Dysmenorrhea referring to painful periods, because there's a secondary cause and it's caused by the pelvic pathology as opposed to occurring at the onset of menstruation. Endometriosis. This is a very high yield condition, and it happens when endometrial tissue implants itself into ectopic places. So this is places other than the uterus is where it's meant to be. So this can include the fallopian tubes, the ovaries, the pouch of Douglas, generally pelvic peritoneum, and the bladder. Endometrial tissue is sensitive to estrogen, just like fibroids were. So when menstruation occurs, it will also occur in this ectopic endometrial tissue, and as a result, there'll be pain or distension at these ectopic sites. What symptoms do you get? The most common symptom for endometriosis is cyclical pelvic pain. And as we discussed, this is at menstruation. But if adhesions have developed because of this ectopic tissue, the pain might actually be constant. Other symptoms in painful periods, we talked about pain on sexual intercourse, pain in urinating, pain when passing stool, and this is because of the ectopic sites that the endometrial tissue has reached. And in a bimanual examination, you might get a fixed retroverted uterus, and this can be caused by the adhesions that develop that prevent the mobility of the uterus. What risk factors? Again, there are general risk factors: early menarche, family history, or uterus or fallopian tube defects. What investigations do we want to do? A pelvic ultrasound can show the kissing ovary sign, where endometriomas bilaterally are stuck together. But often, just because the ultrasound is negative, you cannot exclude endometriosis, because ultrasounds struggle to visualize superficial endometrial tissue. So the gold standard is laparoscopy. And what this enables you to do is to have a direct visual field of what's happening around the uterus. And what you can find is endometriomas, which are dark brown in color. So they're often called chocolate cysts, and they can be found around the ovaries. You can also find adhesions that have developed because of generalized inflammation in the peritoneum, causing these fibrous bands to develop. And you can also find deposits around the peritoneum. How do we manage this? Pain is a key feature in this condition, therefore needs to be managed, and commonly with paracetamols and NSAIDs. If that doesn't work, the next step is to move on to hormonal contraceptives, because it is the estrogen that is driving the pain in this condition. And what you can give is the combined pill or even progesterone-only pills. And what they do is they suppress the ovulation for around 6 to 12 months. This can reduce the size of the lesions and also importantly stop the symptoms. But the difficulty in this is because of the normal age in which endometriosis happens, which is between the 20s to 40s, family planning has to be considered. So in that case, hormonal contraceptive will just not be the correct move. So you'd have to consider surgery. And in the surgery, it'd be, again, laparoscopically excising these ectopic tissues or ablating them. Sometimes when there is deep invasion of the tissue in the bladder, the bowel, you might need to use GnRH agonists to shut off the HPA axis like we discussed, and then perform the surgery so that it's more effective. After surgery, you may want to continue the hormonal treatment to prolong the benefits, but again, you have to consider family planning in this. And this is a more niche condition we're moving on to now, adenomyosis. So this is where there is endometrial tissue that's functional, but not outside the uterus, but it seems to have implanted itself into the muscular layer of the uterus. And again, it's hormonal responsive. It's mostly found in the posterior wall of the uterus and most common towards the end of the reproductive years. Why does it happen? Well, there could be a link between external damage to the uterus and therefore facilitating endometrial tissue to communicate with the muscular myometrium. This can happen in pregnancy, birth, C-sections, uterine surgeries, or surgical procedures in miscarriage or termination of pregnancy. And accordingly, these are the risk factors mentioned here. What symptoms do you get? Increased heavy bleeding, painful periods. They start cyclical as they are hormonally responsive, but it can progress to daily pain, deep pain on sexual intercourse, and irregular bleeding. The key SPA finding would be an enlarged boggy uterus. So that is typical of adenomyosis. What investigations you're going to do? A transvaginal ultrasound is the most common investigation you do. And how do we manage it? Again, pain is a feature here. NSAIDs, if not hormonal, such as the combined pill or progesterone pills. And if the uterine cavity is not distorted, you might want to do IUS. Non-hormonal managements can include hysterectomy, which is curative in essence because the endometrial tissue is only in the myometrium, it's not in anywhere else outside the uterus. Or you can embolize the uterine arteries, which can preserve fertility. You can also do some laparoscopic procedures, but those are further down the line. You don't really need to know about it. Let's move on to SPA 7. I'll launch the poll. Wait for a couple of answers. Waiting for one more answer. Brilliant. Thank you. So I'll stop the poll now. So people have gone for C. And that is indeed the correct answer. So a 6-year-old postmenopausal woman presents to the GP with 2-month history of occasional vaginal bleeding. Her last period was 4 years ago and she's no longer sexually active. On examination, you do observe atrophic changes around the vagina, but no abnormalities in your examinations. What's the best next step? So you do observe atrophic changes around the vagina. So this could well be atrophic vaginitis, but the guidelines are very clear in that all women over 55 with postmenopausal bleeding need a 2-week wait to gynecology for querying endometrial cancer. So let's discuss endometrial cancer. It is an adenocarcinoma, generally, and it's caused by what Shivani discussed as unopposed estrogen. So that's estrogen exposure without accompanying progesterone. And it tends to happen in postmenopausal women about 65 to 70. Symptoms, the one we worry about the most is postmenopausal bleeding. But you can get some discharge or abdominal pain less commonly. In the examination, if there is a large mass, you could feel something either in the abdominal examination or the bimanual. But commonly this isn't the case. What are some risk factors? So the risk factors are actually related to having extended periods of time where you have not ovulated. So that can include, so it's related. So this can include low parity, so not having had as many pregnancies, and so that would have increased your overall estrogen exposure. PCOS, which we'll talk about, which can disrupt your hormones and lead to increased estrogen exposure, just like early menarche, late menopause increases the period of time in which you could have been exposed to estrogen. Also HRT without the accompanying progesterone, because that is only an estrogen source. And similarly, in some breast cancers for premenopausal women, tamoxifen is used, and it's avoided in postmenopausal women. Tamoxifen is an estrogen antagonist in the breast, but unfortunately it's an estrogen agonist in the uterus, so would contribute to this unopposed estrogen. The older you get, the more likely you are. Obesity increases the risk because with older age, because your ovaries aren't your main source of estrogen, this switches to your peripheral fat. And also hereditary factors. If you remember, Lynch syndrome, which can be an inherited cause of colorectal cancer, also has a 40% risk of endometrial cancer. What investigations we're going to do? First, a transvaginal ultrasound. This would help determine the endometrial thickness. If it's more than 4 millimeters, endometrial biopsy is done. Or if there's a high risk, you want to do a hysteroscopy with biopsy. And if we do notice endometrial cancer, we do a staging CT or MRI. So again, FIGO staging is used for endometrial cancer. And it's not very high yield, but it might be worth knowing about it. We've discussed the 2-week wait referral. The precursor to endometrial cancer is endometrial hyperplasia. If when sampling, the hyperplasia is simple or complex, you can just do surveillance biopsies and progestogens. But if there's atypical changes, you'd want to do a preventative total abdominal hysterectomy and bilateral salpingo-oophorectomy. So you remove the uterus, you remove the ovaries, you remove the fallopian tubes, because there's a high risk of development to endometrial cancer. And even if it's confirmed, stage 1 and 2 are typically also hysterectomies, with stage 2 having lymph node removals as well. Stage 3 and 4, you still do as much debulking surgery as you can, but you also consider the addition of chemotherapy and radiotherapy. Let's move on to ovarian disorders. Ovarian cysts, they're fluid-filled sacs in the ovaries. Simple ones contain fluid only. Complex ones are irregular, can contain both solid and liquid. There can be septations in there. It can be increasingly vascularized. We worry about complex ovarian cysts, and they must always be biopsied for suspicion of cancer. Talking about the benign cysts, most common are the physiological follicular cysts. They just represent a developing follicle or a non-dominant follicle that hasn't regressed. A corpus luteum cyst is when the corpus luteum doesn't break down, and they have an increased risk of bleeding. Germ cell tumors, the pictures you see sometimes, and these are the somewhat disgusting ones, which can include various epithelial tissues like skin, bone, hair, and teeth. They're mature cystic teratomas. That's what describes the multiple epithelial tissues, and they're the most common benign ovarian tumor in women under 30. They can be bilateral. They tend to be asymptomatic, but because of their size, they can undergo torsion, which is when it twists around its own axis, causing acute pain. There are some epithelial tumors as well, which reflect the most common ovarian cancers. Clinical features, they tend to be asymptomatic, picked up incidentally. And chronic pain is a key feature, as well as the pressure symptoms. If they bleed, rupture, or tort, acute pain can happen. Investigations, ultrasound. In premenopausal women, small and simple, likely benign, so we repeat the ultrasound and refer if it carries on. Postmenopausal women, we refer to gynae for all cysts and suspicion of cancer. Complications, as we discussed, bleeding, rupture, ovarian torsion. Ovarian torsion, they need surgical input. Let's move on to this SBA. For sake of time, we'll just carry on with it. So, a 35-year-old woman presents to the GP with a 4-month history of abdominal pain and bloating. She has noticed weight loss over this time and says that this is because she feels very full when trying to eat. No masses are felt. Given the likely diagnosis, what investigation would we do? And in this case, it would be the serum CA-125. So what we think could be going on with abdominal pain and bloating, with the weight loss and early satiety, is ovarian cancer. So what we do in primary care, the guidelines say to first measure the CA-125. Ovarian cancer, as we discussed, the majority are epithelial, 90%, and of this 90%, 80% are serous carcinomas, happen around 60 years old, and the symptoms can be vague. They can include abdominal distension, pain, feeling full early, urinary symptoms, stool symptoms, weight loss, abnormal bleeding, very vague symptoms. Rarely, you can get ascites in the examination. That would indicate skipping the CA-125, skipping the ultrasound, immediately referring. And similarly, if you notice a mass on abdominal examination. Risk factors is related to more ovulations, so more surface epithelial irritation. Lynch syndrome can cause it, more commonly BRCA1 and 2 mutations. Not having been pregnant before, a longer duration of having had periods, smoking, and obesity. What protects you? Stuff that reduces the amount of ovulations you have. So the pill, having multiple children, and breastfeeding. Continued. This is the general pathway that you can have a look at in your own time, but it's generally saying ascites on new mass, 2-week wait. Otherwise, suspicions, measure the CA-125, increased, ultrasound, abnormal, 2-week wait. Otherwise, consider other causes. Also do general blood tests. And in confirmed cases, staging CT is needed. How do we manage it? Surgically with staging laparotomy initially. Adjuvant chemo can help, and you follow up for 5 years. So again, SBA 9, we'll just talk through this. A 27-year-old woman presents to infertility clinic after trying to conceive for 2 years. She's also noticed increasing amounts of facial hair and skin thickening and hyperpigmentation in both axilla. Which of the following is needed to confirm the most likely diagnosis? So what this sounds like is signs of hyperandrogenism. so the facial hair, skin thickening, hyperpigmentation. Also, she's at the infertility clinic, so difficulties conceiving. This sounds like PCOS. So the diagnostic criteria suggest oligo or anovulation as being required to confirm the diagnosis. The Rotterdam criteria clearly say 2 of the 3 is needed: oligo or anovulation, clinical or biochemical hyperandrogenism. So in this case, we have the clinical findings, or polycystic ovaries on imaging. Only 2 of the 3 is needed. You can be diagnosed with PCOS without polycystic ovaries on imaging. This is an endocrine disorder, really, characterized by multiple cysts, ovulation disorders, and increased androgen. The etiology, so excess LH can stimulate the ovaries to produce more androgens, and there is also insulin resistance in the body because PCOS can form part of metabolic syndrome. So the insulin resistance suppresses the sex hormone binding globulin and allows more circulating androgens. Androgens suppress the LH surge, and therefore follicles don't develop in the ovary and remain cystic. Risk factors: diabetes, family history, although the risk factors are poorly defined in reality. Symptoms: oligomenorrhea or amenorrhea, so lack of periods or reduced amount of periods, infertility because of the aforementioned symptom, hyperandrogenism, so hirsutism, obesity, and the examination findings here. So the hyperpigmentation, the axilla, was a sign of acanthosis nigricans. The acne and hirsutism, signs of hyperandrogenism, as well as male pattern hair loss. Investigations: the testosterone can actually be normal, but the sex hormone binding globulin can be low, in line with the etiology we discussed. The LH tends to be significantly greater than the FSH, and there can also be an increased prolactin. And on ultrasound, you can see the follicles, 12 or more in a single ovary. We discussed the Rotterdam criteria already. How do we manage PCOS? PCOS requires a very multidisciplinary approach. There are many complications with PCOS, which require a lot of specialists to be involved in the care. It can be part of metabolic syndrome, so this could include diabetes or gestational diabetes when pregnant, cardiovascular disease, which increases your risk of, subfertility, so the fertility clinics. It can increase your risk of endometrial cancer because of increased estrogen exposure, and there are some links to obstructive sleep apnea and psychological disorders. But what do we recommend first? This is lifestyle changes: weight loss, improved diet, so a low glycemic index diet, just like you'd recommend in diabetes, and regular low intensity exercise. Otherwise, the combined pill can help with some of the androgen symptoms of the hirsutism, can regulate your cycles and reduce acne. But when someone with PCOS wants to conceive, weight reduction and lifestyle changes first, but clomiphene is often used, and metformin is a secondary agent. And metformin is to reduce the general insulin resistance and help with weight loss, and clomiphene helps with ovulation. So the last bit of my section, we're talking about ectopic pregnancy. With this SBA, a 20-year-old lady presents to the hospital with right iliac fossa pain. She has an IUD in situ. A pregnancy test is positive. A transvaginal ultrasound shows a fetus with a detectable heartbeat in the left fallopian tube. She's stable. No any surgeries before. What's the most appropriate management? So there is a detectable heartbeat. So therefore, we'd go for a salpingectomy. So we can't do expectant management. We can't do medical management because there is a detectable heartbeat. So we have to do surgical management, which is removal of the fallopian tube. Ectopic pregnancies. So that's any pregnancy implanted outside the uterine cavity, most commonly the ampulla of the fallopian tube. Risk factors include having had a previous ectopic, PID, which has caused adhesions, and endometriosis, which also causes adhesions. The IUD and IUS also increase the risk, as does previous surgery. Symptoms: with ectopics, you can get lower abdominal pain, you can get bleeding. You also can get referred pain if there's irritation to the diaphragm, and that's shoulder tip pain. And you can get brown or prune juice vaginal discharge. When you do an examination, you can get cervical excitation by manual and adnexal tenderness, but ideally you'd not want to be feeling for the adnexa, because then you're risking rupture of the implanted fetus. When it does get ruptured, if it does, hemodynamic instability follows. So that's pallor, increased CRT, tachycardia, hypotension, peritonitic symptoms, so rebound tenderness, guarding when you examine the abdomen. And what investigations? Pregnancy test, looking for the beta HCG, a transvag ultrasound as well. And that's to confirm that there's no intrauterine pregnancy. The diagnosis: positive pregnancy test, ultrasound. It should identify intrauterine pregnancy. If it doesn't, transvag ultrasound, still nothing visible. Beta HCG, if it's high, you're thinking ectopic. If it's low, monitor again in 48 hours. It could just be a very early intrauterine pregnancy. In that case, the beta HCG would double rapidly. If it halves, we're worried about miscarriage. Anything in between in the gray area, probably an ectopic. How do we manage it? First, if you're presented with this in an OSCE situation, you'd want to do an A2E approach to make sure the patient is stable. And if they are unstable, stabilize the patient first. Once we've done that, generally how we manage ectopics is that if the size of the fetus is below 35 millimeters, if it's unruptured, no fetal heartbeat, the mother's asymptomatic, low beta HCG, we just monitor over 48 hours. It could just go on its own. If the HCG rises, intervention would be indicated. Medical management is indicated when unruptured, the mother's not really experiencing any pain, and importantly, there's no fetal heartbeat. And the HCG must be below 1,500. We give methotrexate, but the patient must be followed up because this could fail, and there are side effects such as myelosuppression, hepatitis, renal failure that have to be considered. Surgical management is dependent on size, if they've ruptured, if there's significant pain, and if there's a visible heartbeat as well as a high HCG. What we want to do first is a salpingectomy, which removes the tube, but because previous ectopic pregnancies are a risk factor for a further ectopic pregnancy, the mother might already have had a salpingectomy. In that case, we want to preserve fertility and do a salpingotomy, in which they simply cut the tube to remove it. And this is in the aim of maintaining fertility. But there are risks to this procedure. The general anesthetic risks: you might damage the bowel, bladder, ureters, or nerves associated. Also bleeding, infection risks. So if everyone doesn't mind filling out the feedback, the 2 people that I've stuck through, if you could fill that feedback for mine, and then we'll move on to Hassan's part, which is miscarriage and breast. I'll stop sharing. I hope everyone's had a chance to scan the feedback.
Cheers, thanks, Zenel.
Thanks, Hassan. I'll let you take over.
Which slide did you end on, Zenel? Is it feedback?
Yeah, you start on miscarriage.
I start on miscarriage. Okay. Just give me a second. It must be. Central European. Why does it keep jumping back? Right. Sorry about that, guys. Can everyone hear me?
Good to go.
Camera on. Right. So yeah, my name is Hassan. I'll be going on from miscarriage. So for those of you that are still with us, a miscarriage is defined as a loss of pregnancy at less than 24 weeks gestation. Because typically past 24 weeks, pregnancies are considered viable. But prior to 24 weeks, that's where the definition of miscarriage comes in. And they typically tend to occur more within the first trimester, so basically within about 12 weeks. And they're the more common ones compared to late miscarriages. But the notable risk factors that I think you guys will probably want to remember, one easy one to remember typically is age. So the older the mother is, the more likely they are to miscarry. A previous history of miscarriage is also another one that's important to remember. Obesity and smoking are risk factors. Any sort of chromosomal abnormalities can contribute to the risk of someone having a miscarriage. So chromosomal abnormalities within the fetus, and pre-existing uterine anomalies as well. So this brings into question of mind things like fibroids or endometriosis or adenomyosis. These will all contribute to an increased risk of miscarriage. Antiphospholipid syndrome as well is one that you may want to remember from fourth year. So the whole sort of I think four things are increased VTE risk, liver diverticularis, miscarriages. I forgot the other thing as well, but that's another important one that you'd want to remember from fourth year as well. In terms of the symptoms, so the main symptoms are things like vaginal bleeding. Your patient will begin to pass clots and they'll be complaining of passing clots, and the pain that they'll get will be a cramping sort of pain that's suprapubic. If there's excessive bleeding, then they can present with hemodynamic instability. However, in general, if you're trying to differentiate between an ectopic pregnancy and a miscarriage, you're probably in the ectopic pregnancy, you're probably more worried about lighter bleeding, but an excessive amount of pain, and the bleeding almost disproportional to the pain, and even things like systemic shock and upset. Whereas with a miscarriage, I think we're talking about presentations of more cramping pain with heavier bleeding. And the examination finding, as said before, they can present with hemodynamic instability if they've bled a lot. And the cramping pain can present as abdominal distension and tenderness. But on an actual speculum exam, you can see things like products of conception potentially, bleeding, of course, and the diameter of the cervical os is important to make a note of, because that's how you will classify miscarriages moving forward. On a bimanual exam, you may as well find things like uterine tenderness. In terms of investigations, typically you'll use a transvaginal ultrasound, because some of the key things that are important in terms of how you want to manage a miscarriage are getting things like the fetal heart and also the crown rump length. So if it's less than 7 millimeters, this suggests that the gestation is a bit too early to find a fetal heart. So you may have to repeat the transvaginal ultrasound in about 7 days. Some of these are getting a bit more specified, and you may not need to remember them. But I mean, the information is here if you want it. The fetal pole, if that's not visible, but the gestational sac and the yolk sac are visible, then you have to look at the mean sac diameter. I didn't learn this too much in depth. I don't think you need to either, but it's there if you want to read of it in your own time. In terms of the blood tests, these are important. Full blood count, because you want to establish things like anemia, just to have a look at sort of how much blood loss has affected the full bloods. Beta-HCG is also important as well, because you're also, in the differential, overlapping a miscarriage is also an ectopic pregnancy. So getting a beta-HCG can really help you differentiate between things like a viable intrauterine pregnancy, an ectopic pregnancy, and a miscarriage as well. In terms of, you'd also want to get a blood group and a Rous status for Rous negative mothers, and blood group as well if you're worried about excessive bleeding and needed to transfuse. And you may want to get swabs as well if we're worried about vaginal infections. So a 30-year-old lady presents to the hospital at 20 weeks gestation with vaginal bleeding. On speculum examination, it shows light vaginal bleeding with a closed cervical os. On ultrasound, there is a fetus in the uterus, but no fetal heartbeat. What type of miscarriage is this describing? So if anyone wants to put it in the chat, maybe in the interest of time, I may rush through questions a bit more. But yeah, if anyone wants to throw anything in the chat, I'll just say it out loud. There's only 3 of us. Okay, that's fine. Yeah, so this is a missed miscarriage. The key things in the question that are really highlighting the missed miscarriage are the fact that there's no fetal heartbeat, the fetus is still in utero, and the cervical os is closed. So basically what's happened is that the fetus unfortunately died in utero, and it's gone sort of unnoticed by the mother until some light vaginal bleeding, until she presented with some light vaginal bleeding. In terms of differentiating this from other types of miscarriages, so we can break it down into threatened, inevitable, incomplete, complete, and missed. And typically what's going to help you determine which one is which is also helping remembering whether the cervical os is closed or open in either scenario. So threatened is basically the patient presents with bleeding and the cervical os is open, but there is a viable intrauterine pregnancy on the scan. So basically you see that there is a fetus in there, it's healthy, it's got a heartbeat, but the reason you're calling it threatened is because there's bleeding. But the cervical os is closed. So it's not like, for example, inevitable, where the cervical os is open and the pregnancy is still intrauterine. But the cervical os being open almost makes it like it's inevitable that it's going to happen and that the mother is going to miscarry. Whereas in a threatened scenario, the cervical os is closed. So you're at risk of it miscarrying, but it's not exactly enough. There's not enough to say yet that will definitely happen. Incomplete will be more sort of intense pain and heavy bleeding, and you'll find the cervical os open. But the thing is that you'll see a mix of passage of products of conception, but some of the products of conception will remain in the canal as well. So it's incomplete in the sense that they haven't passed all the products of conception, right? In terms of complete, there'll be a history of pain and bleeding, but this history will present with a more sort of resolved picture of that settled. They've come in now just to sort of establish what happened. And the cervical os will be closed and the uterus will be empty on a transvaginal ultrasound. So in effect, basically, the miscarriage has taken place. There's no products of there's no products of conception within the uterus, and the cervical os is closed. So it's like the process is complete, right? And in terms of missed, I already covered it. Again, saying that the patient doesn't really present with too many symptoms. They may have some light bleeding, and they won't really realize that they've been through a miscarriage. The cervical os will be closed, and there will actually be the fetus still in the uterus on a transvaginal ultrasound, but it will be a non-viable uterine pregnancy because, for example, there'll be a missing heartbeat. And in terms of how you manage it, you break it down to conservative, medical, surgical. So conservative basically will be, you'll give the patient about 1 week to 2 weeks just to allow the miscarriage to complete. And you'll genuinely be comfortable with doing conservative management if you're confident that the infection risk is low and also the bleeding risk is low as well. Because you obviously don't want to send any patient home with a high infection risk where the miscarriage could spiral into some kind of sepsis, or if they have a very high bleeding risk, and you send them home, they end up bleeding excessively and they become hemodynamically unstable, and you don't want to face complications like that. So generally, you're conservative for patients where you're not really worried about infection. You're also not really worried about excessive hemorrhaging risk, right? And in terms of the medical, this is when medical and surgical is when you're beginning to wonder about, okay, you're a bit worried about infection risk and you're a bit worried about bleeding risk. The medical management, you'll use vaginal misoprostol, and you may give antiemetics as well if the patient feels sort of queasy or sick. But obviously, you'll give accompanying pain relief. And whenever you do medical management, you need to follow up in general with a pregnancy test 3 weeks later, just to ensure the pregnancy has been terminated. Right? And in terms of surgical, this is basically where you're considering about actually using surgical instruments to go into the uterus and remove the products of conception yourself. So this can be done under local anesthetic if the patient is less than 12 weeks gestational age, or if it can be done under general anesthetic if they're over 12 weeks. And the absolute definite indications to do this will be, for example, if the patient is presented with some kind of infected picture, so like a sepsis, and if they're just straight up hemodynamically compromised, and you have to sort of terminate the miscarriage there and then. Yeah. So now we're moving on to vulval cancer. This is one of the sort of, it's not one of the most common cancers in gynecology. The ones that you're gonna have sort of more at the forefront of your mind will be things like breast, endometrial cancer, ovarian cancer. Vulval cancer often kind of goes missed, or some people sort of don't really cover it, but I think it's worth covering regardless. We're talking about skin here, so it's a squamous cell carcinoma in most instances, and it tends to take place in the labia majora. And the incidence in this particular case is strongly related to age. So we're typically talking about women that are quite advanced in their age, so quite elderly women. They'll be the ones where they'll be the typical patients who may develop a vulval cancer. And just like cervical cancer, there is also, for example, a previous risk factor of vulval intraepithelial neoplasia. But I think a common risk factor that I used to remember quite easily was lesion sclerosis. If you're thinking about skin that has become very inflamed and plaque-like and itchy, it's a very easy sort of precursor to something like vulval cancer. HPV, just like cervical cancer, is a risk for vulval cancer as well. And the presentation tends to be quite sort of, I don't think bleeding is the most common presentation of it, but typically the question will go mentioning that an elderly woman has a palpable lump on their vulva, and it may be ulcered, and it may be bleeding due to the ulceration. There may be itching as well, they may have pain, and because the presentation is more subtle, it can be a sort of incidental diagnosis. In terms of investigation, you want to do a sort of a bimanual vaginal examination, and then you'd also want to biopsy the lesion as well. And you'd also want to potentially consider things like a cystoscopy, proctoscopy, just to see if there's cancers that have moved anywhere from the vulval cancer. So, for example, into the bladder, or also staging with regards to MRI, as always. And a 2-week wait referral is basically if there's any unexplained vaginal lump or unexplained vulval bleeding or ulceration, you will give the patient a 2-week wait referral for vulval cancer. Again, the staging system used is the FIGO system, but I don't think you need to go into too much detail and learn that. I think it's just nice to be aware of it, but that's about it. With regards to the management, it's a surgery, and you'll do something like a wide local excision, or they may just remove the entire vulva and do a radical vulvectomy if it's multifocal disease with bumps at different sites. And in terms of there'll be accompanying sort of reconstructive surgery as well, and they'll also do a sentinel lymph node biopsy just to see if the cancer is potentially spread anywhere else. And the complications are as sort of standard with a lot of surgeries, so wound infection. And in this particular area, you can get urinary and fecal incontinence with any surgery in general to the perineum or the vagina. And advanced vulvar cancer, you'll consider using radiotherapy and baby chemotherapy. So moving on to pelvic inflammatory disease. So pelvic inflammatory disease is defined as an infection of the upper genital tract, and it will affect anywhere from the uterus to the fallopian tubes, the ovaries, and even the peritoneum. And PID, we're typically thinking about a younger population, so somewhere between 15 to 24-year-olds. But basically what happens is the bacteria from the vagina or the cervix will spread to the upper genital tract, the upper genital tract being things like the uterus, the fallopian tube, the ovaries, and it will trigger an inflammatory response it's typically the bacterial infections that we're thinking about in this instance tend to be chlamydia and gonorrhea. They tend to be the most common causes of pelvic inflammatory disease. So in patients who are presenting with this sort of dull bilateral pelvic pain, fever, low-grade fever and vaginal discharge, you'd be interested in also getting an accompanying sexual history from them as well, just to see if there's any risk of STIs. And the risk factors, as I said, sexually active, recent partner change, so whether they don't know the STI status of the new partner that they've acquired, not using protection with regards to sexual activity, or having a previous STI. These all run the risk factors for pelvic inflammatory disease. Also, in general, any instrumentation that involves basically moving from the lower genital tract to the upper genital tract runs a risk of dragging bacteria up there and causing it. So in terms of symptoms, as I said, it's a lower abdominal pain, and in advanced cases, they can present with like sort of a low-grade fever, but also abnormal discharge, dysuria, and deep dyspareunia as well. So specifically on sexual activity, there's a deep pain that's felt from sexual activity. And on examination, if you do a bimanual exam, you'll feel a tender uterus and also a tender cervix. And there'll be cervical excitation, which I think they also call chandelier sign. But basically, it will be very, very tender if the cervix is palpated or moved. And you may find abnormal discharge as well. In terms of investigations, so you want to do an STI screen because, as I said, chlamydia and gonorrhea tend to be the two most common causes of it. So you'd also do things like get endocervical swabs because you're swabbing for gonorrhea and chlamydia. But because the patients can present with dysuria, you'd also want to get a urine dipstick as well, with microscopy and culture. You'd also always get a pregnancy test. Anyone presenting with lower abdominal pain, you must do a pregnancy test. And a transvaginal ultrasound may be indicated if in a bimanual you found a mass in the lower abdomen. And in terms of management, it's typically just sort of clearing the STI, for example, that may have caused it. So you may do a 14-day course of broad-spectrum antibiotics. It may be, so for example, a combination of doxycycline, ceftriaxone, ofloxacin, and metronidazole. And as you can see, sort of doxycycline is targeting the chlamydia, and the ceftriaxone is targeting gonorrhea, and the ofloxacin and metronidazole are targeting other potential causes of pelvic inflammatory disease that are just less well known. Paracetamol as well, just in general for pain and potential fever. And you'd also need to test and treat all the partners from the last 6 months of a patient with PID. In terms of the indications for hospital admission, if a patient's pregnant, that's a big one because you're worried about the infection spreading to the uterus, the infection spreading to the fetus. Any systemic upset, so fever, nausea, septic pictures. The minute any peritonitis begins to get involved, so patients that have rigidity and guarding, and if the patient isn't responsive to antibiotics as well, these are all indications where you may want to take a patient with PID for hospital admission. And the complications that can come from it, there is an increased risk of ectopic pregnancy with PID and also infertility. And the sort of rogue complication that it's very SBA-able, you learn it, is Fitzhugh-Curtis syndrome, which is basically where you present with right upper quadrant pain, and I think deranged LFTs following a sort of long history of PID. Right, so moving on to breast now. Breast is it's fairly short in terms of well, at least in medical school, not in real life, but in medical school, I think you already get about 1 week of it in 5th year, and I don't think there's not a lot of content to learn. I think it's very easy to learn, and it's also the questions are also fairly straightforward. But starting with breast cancer, it's the most common cause of cancer in women. And it's also the second most common cause of death from cancer in the UK. And in terms of how you'll divide breast cancer up, you'll divide basically breast cancer into either ductal or lobular. And then further dividing it from ductal or lobular, each side will either have an in situ version or it'll have an invasive version. So it'll be a ductal carcinoma in situ, which is DCIS, or an invasive ductal carcinoma. And lobular as well, there'll be a lobular carcinoma in situ or an invasive lobular carcinoma. There are some other sort of more rogue tumors as well, like I think pronounce it Phyllodes tumor, but the main ones to be aware about are ductal and lobular. Some other definitions that they've mentioned here: Paget's disease is basically where if patients present with eczema that's particularly on the nipple, you'd be worried about a possible underlying malignancy because there is a clear association between the two. I don't know how common it is, but it's just something to sort of keep in mind. It's very SBA-able as well. And inflammatory breast cancer, which is basically due to cancer cells that block the lymphatic drainage of the breast. So, which of the following patients need a secondary care referral based on their risk of getting breast cancer? Just in the interest of time, has anyone put anything in the chat? Feel free to say it out loud as well. That's all right. Right. So the answer was a 43-year-old woman whose father was diagnosed with breast cancer at age 70. Now, this is moving basically into the risk factors for breast cancer, but also the risk factors that would prompt screening in someone for breast cancer. And we'll get onto that in a couple of slides. In terms of the risk factors for breast cancer, one of the most important ones are things like family history, and in particular, BRCA gene mutations, which are autosomal dominant. And there's a slight distinction between BRCA1 and BRCA2. BRCA1 is important to be aware of because this one is particularly associated with high-grade triple-negative cancers. Triple negative meaning that they're estrogen receptor negative, progesterone receptor negative, and HER2 receptor negative as well. The reason they're high grade is because they're very difficult to treat because you can't target them from a hormonal perspective and you can't target them from a immunological perspective either. In terms of BRCA2, this one is important to keep in mind because it actually runs a risk, I think, of increased ovarian cancer and I think a number of other cancers as well. Don't quote me on it, but for some reason, part of me wants to say pancreatic cancer is also associated with BRCA2. You guys can validate that in your own time. But the BRCA2 gene mutation as well also runs the risk of estrogen receptor and progesterone receptor positive tumors. So one of them, so BRCA1 is high-grade triple-negative cancers, whereas BRCA2 is more likely to be an estrogen receptor, progesterone receptor positive tumor. Other important risk factors are breast cancer is correlated basically with estrogen exposure. So anything that has lengthened the amount of time that you've been exposed to excessive amounts of estrogen will run your risk up of breast cancer. So it's typically this triad of sayings of saying early menarche, late menopause, and nulliparity. So early menarche was that basically you started your periods very early, and you also had a late menopause, so you stopped your periods very late. So that's a very, very extended time of estrogen exposure, and nulliparity as well, which is basically where you didn't have any interruption in your estrogen cycles and your ovulatory cycles. So you've been exposed to a very long time to an elevated amount of estrogen. And as mentioned before, by Zenel and by Shivani, hormonal replacement therapy and COCP are also risk factors for breast cancer. And conversely, the protective factors are things that are kind of countering excessive ovulation cycles. So things like breastfeeding and multiparity are sort of self-explanatory because they reduce the amount of ovulatory cycles, which reduces your risk. And other risk factors as well, advancing age is in general, mostly safe to say. If you're really struggling to think of risk factors for a cancer, advancing age is generally safe to say is a risk factor for cancer. And obviously previous breast cancer as well. Yeah. So the presentation will ultimately divide into either whether they're symptomatic or asymptomatic, because patients may not present very symptomatic. They may be largely asymptomatic with just noticing a lump on their breast. In terms of the screening, you should do a lot to commit these guidelines to memory because you will be asked about them a lot. So in the UK, I think women are entitled to every 3 years between the age of 50 and 70 a mammogram. And after the age of 70, women can book their own screening and they can attend screening, but as I said, they have to book it themselves. They're not sort of regularly followed up on it between the ages of 50 and 70. And as mentioned before, as I was going to get into it, certain high-risk groups are screened under the age of 50, and that's what that SBA prior was about. So you have to consider things like familial risk factors. So some patients may not have a personal history of breast cancer. They can be managed in primary care if they only have one first-degree relative or a second-degree relative diagnosed with breast cancer. But none of the following of these need to be present in the family history. That being a bilateral breast cancer in like a first-degree relative, any instance of male breast cancer, any previous history of ovarian cancer, or if they have Jewish ancestry. These are the ones that came to mind the most. I don't know how in-depth you want to go with sort of memorizing familial risk factors for breast cancer because the guidelines are quite long. But I think maybe off the top of your head, it's quite easy to remember any instance of bilateral breast cancer in the family or male breast cancer as reasons to offer screening under 50. And yeah, a secondary care referral is indicated for anyone without a personal history of breast cancer who have any of the following. And as I said, they're quite extensive. So if you've got one first-degree male relative who's been diagnosed with breast cancer at any age, then you'd need a secondary care referral. One first-degree relative with any bilateral breast cancer, where the first primary was diagnosed under 50, just as a small nuance to appreciate. Again, secondary care referral is needed. And the other ones as well, I would advise you to sort of look into in your own time and have a rough idea in your head, loosely, of the referral criteria, but I don't think you need to sort of drain yourself really trying to memorize every bullet point. In terms of the referral criteria, so looking at the 2-week weight referral criteria, anyone aged 30 and over with an unexplained breast lump requires a 2-week weight referral. It doesn't matter whether pain is present or not. So if a 31-year-old woman or a 30-year-old woman presents, or a male presents with an unexplained breast lump, you want to refer for a 2-week weight referral. In terms of being aged 50 and over, you can be aged 50 and over with any of the following symptoms in only one nipple, and those symptoms can include discharge, retraction. Other changes of concern can include things like pain or skin changes, like we talked about, like Paget's disease of the nipple. So aged 50 and over with any one of these symptoms in only one nipple only will warrant a 2-week weight referral. In terms of considering a 2-week weight referral for breast cancer, if you, for example, on a breast examination, identify skin changes that are concurrent with breast cancer, or any person aged 30 and over with an unexplained lump in the axilla, then you'll consider doing a 2-week referral. But a non-urgent referral is anyone aged 30, anyone aged under 30 with an unexplained breast lump. It'll be a non-urgent referral for that patient. Okay. Now, this is also a term that you want to sort of have cemented in your mind, especially with regards to OSCE, with any stations regarding breast surgery, and that is triple assessment, because they'll ask you about this a fair amount, and they'll also want you to answer with this a fair amount as well, because it is the way people with potential underlying breast disease are managed in clinical care. So triple assessment is basically history and examination, the imaging, and then the biopsies. And the history and examination, now there are the examination is basically doing the breast exam, and they'll stratify their findings of a lump of the total examination as being a normal exam, benign findings, indeterminate, suspicious, highly suspicious, malignancy. And you may see it when you do your breast rotation in the notes or something. They may say that history and exam was P2 or P3 or P4. Again, have a general sort of outline of what they mean, knowing that from P1 to P5 is increasing suspicion and severity. But you don't need to sort of fully commit it to memory. In terms of the imaging, there's 2 lines of imaging that you can go between for when you're looking at breast pathology. So an ultrasound can be done for patients under 40 years old, whereas a mammogram can be done for patients over 40 years old. When I learned it, I think it was 35 years old was also acceptable for doing you could do an ultrasound beneath 35 years old, but older than 35 years old, you probably want to do a mammogram. I'd ask you to sort of double check that in your own time. But here it says under 40 years old as an ultrasound, whereas over 40 years old as a mammogram. And just to sort of consolidate that, the reason you do that is I think because I think in younger breast tissue, it's more dense. So doing a mammogram would just give you an image that is just full of a white, dense opacity all around the breast. So you won't actually be able to discern properly any suspicious lumps or consolidating lesions within the breast. Whereas over 40 years old, in older patients, the breast tissue is less dense. So you can do a mammogram as an easier way to assess the breast for any concerning lesions. And in terms of the biopsies, you'll split it into either a fine needle aspiration, punch biopsy, or a core biopsy. The core biopsy is for you to look at the tissue. The punch biopsy is for you to look at skin samples, which is an important distinction to note in terms of when you're mentioning them. And fine needle aspiration cytology is basically when you're looking at fluid or cysts. So yeah, triple assessment is history and examination, imaging, and biopsies. And another important thing to note is that generally there should be a line of concordancy throughout the entire assessment. So it wouldn't really make sense, for example, for someone to state that from the history in the exam, they're P4, which is suspicious, but then their ultrasound or mammogram yields nothing. Or someone to say that they've got a normal examination, but then they've got suspicious imaging and biopsies. In general, they should all kind of follow one after the other. Yeah. And this is the TNM staging. Again, I think all of us kind of have a brief overview at this point. You don't need to memorize it or anything. It's just kind of knowing that, T is regarding the size of the tumor, N is talking about the lymph node involvement, with N0 being no regional nodes, and M is with regards to metastases. So M0 basically being that there's no metastases to know. Right, so a 50-year-old postmenopausal lady presents to triple assessment clinic with a 2-centimeter breast lump. A mammogram, biopsy, and staging CT showed that this single estrogen receptor positive, HER2 receptor positive tumor. What is the most appropriate next management option? So again, you can feel free to type it in the chat, or someone can say it out loud. I mean, I was going to move on fairly quick from it, just for the sake of time, but Nope. Okay. Right. So the answer for this one is wide local excision. And the reason it's a wide local excision is because in this instance, it's a breast lump, I think that's under 4 centimeters. And so it's a small solitary tumor. And in addition to that, in this instance, you consider surgery as the first line management. So just sort of getting rid of the lump altogether. So in terms of the treatment for breast cancer, surgery as a form of treatment is divided into either a wide local excision or a mastectomy. And the hormonal treatments are divided into basically whether the patient is estrogen receptor positive or not. And if they are estrogen receptor positive, you need to consider the menopausal status of the patient. So are they premenopausal or are they postmenopausal? If they're premenopausal, then you'd want to consider using tamoxifen, because if they're postmenopausal, you want to consider using aromatase inhibitors. I think the reason for that, because in postmenopausal patients, I think the uterus is the main source of estrogen. No, the uterus, I think, produces hormones that can be aromatized and converted into estrogen. So you want to inhibit that process in postmenopausal patients. Whereas in premenopausal patients, you don't need to do that. You just need an estrogen receptor antagonist, which comes in the form of tamoxifen. But it's also, as mentioned before by my colleagues, tamoxifen runs the increased VTE risk and the concurrent uterine carcinoma risk, so endometrial cancer. And then in terms of immunotherapy, this is largely dependent on whether someone is HER2 receptor positive. So if they are HER2 receptor positive, you can use things like trastuzumab, but a common side effect to note is cardiotoxicity. And in terms of chemotherapy, there may be neoadjuvant, adjuvant, and it may also be used in metastatic disease. So the surgery, comparing between wide local excision and mastectomy, in general, when you're thinking about it, so mastectomy is removing the entire breast, whereas wide local excision is just removing, trying to remove the lump only and preserve the breast as much as possible. So some of these criteria sort of make sense. You'd be considering a wide local excision, for example, if it's just a solitary lesion, if it's peripherally located, and if it's a small tumor relative to the breast, it's easier to just sort of remove the lump and try and preserve the breast as much as you can. But a mastectomy, you'd be more interested in doing that if the lesion is centrally located, if it's a multifocal lesion, so there are many lesions that need removing, and if it's also a large tumor relative to a small breast. So it becomes very difficult to just preserve the breast tissue in that instance. But an important distinction to note is that with the wide local excision, you always require radiotherapy from it, whereas with a mastectomy, you may not require radiotherapy, or you may also require it if you meet the criteria, for example, of pathological nodes located in the axilla, so the armpit, or if the tumor is more than 5 centimeters. And in terms of prior to the surgery, you'd always be interested in examining the axilla to feel for any palpable lymphadenopathy. If there's no palpable axillary lymphadenopathy, you might want to do an ultrasound to see if there's any lymph node enlargement itself. And then you'd also be interested in doing a sentinel lymph node biopsy, which is basically you trying to identify if any of the cancer cells from the breast cancer have drained to the sentinel lymph node into the axilla and whether they need removal. Because then that dictates whether you need to do an axillary node clearance, which is basically where you remove all the axillary nodes, so all the lymph nodes in the armpit, to make sure that you can stop any risk of the breast cancer remaining or spreading. But the complications of an axillary node clearance would be things like lymphedema. So they may give you an SBA where someone's had axillary lymph node clearance following mastectomy or a wide local excision, and the patient's now presented with a swollen arm. They're presented with a swollen arm because the lymph node fluid can't really drain properly because you've removed a lot of the nodes. So this is just an example diagrams laying out what a sentinel lymph node biopsy is. So injecting the radioactive substance into the tumor and allowing the substance to drain to the local sentinel nodes to see if the tumor is linked to these nodes. So the final two slides, now that we're at the end, is just sort of all the other conditions in breast. As I said, with breast surgery, the main thing you probably want to learn about it is breast cancer, but the other conditions are helpful to know as well. So you can split these into basically disorders of development, disorders of cyclical change, and disorders of involution. So in terms of disorders of development, a common lump in the breast that's often found in younger patients is a fibroadenoma. And this is described as a mobile firm lump. Sometimes it's called a breast mouse, I think I was told. But basically, on examination, you'll feel a firm lump. It will be very motile under the skin, and the patient will typically be young. And this can be observed and just monitored if it's less than 3 centimeters. But if it's over 4 centimeters, you consider biopsying it because you may be a bit worried about something that isn't a benign lesion. And the phyllodes tumor, as I said, it's rare. It can be benign or it can be malignant, but it's typically a much faster growing lump in the breast. It's rare. In terms of disorders of cyclical change, one that you may see in questions and also in clinic will be things like mastalgia. So this will present basically as a cyclical pain, and the pain will be related to the menstrual cycle. So be sure to sort of clarify that in the history in terms of when the pain comes on, what it's exacerbated by. The patients will often report it'll be around their menstrual cycle. And the management for it is just sort of lifestyle measures. So wearing a supportive bra, avoiding any triggers that the patient may identify, so caffeine or alcohol, and analgesia as needed. And in terms of disorders of involution, so fibrocystic disease is another one that's important to be aware about, because patients can present with, it's described as lumpy breast, but basically in both breasts there are a number of lumps that are felt, and it may or may not present with pain. And these the occurrence of these lumps within the breasts tends to it's affected by the menstrual cycle, and I think it follows it in some ways. So it'll be a history of pain and lumps in the breast, again, along with sort of in conjunction with the menstrual cycle. And some other important ones to differentiate here. So I always used to draw a distinction between mammary duct ectasia and duct papilloma because they cause a discharge that I think it's helpful to draw a distinction between. So mammary duct ectasia is basically where the breast ducts, they dilate, typically around menopause. It's usually a natural process, but sometimes it can result in a green discharge. And there may be a tender lump that is felt around the areola. And the risk factor that you're taught to remember, because it's heavily associated with it, is smoking. The duct papilloma, on the other hand, this is where the discharge from a single duct will be blood-stained compared to green in mammary duct ectasia. And it will be presenting within a patient at about 40 to 50 years old, but it will be a blood-stained discharge from the nipple. Fat necrosis is basically where if on breast examination you find an irregular breast lump, if there's a preceding history of trauma to the breast, and also obesity can run the risk, increase the risk of fat necrosis in the breast. It's a hard, irregular lump. And then finally, mastitis, which is sort of linked a little bit with obs and gynae, is basically where you'll get inflammation of the breast and swelling as well. It's typically sort of like around the breastfeeding period with, the excessive production of milk, and sometimes the milk isn't draining. So the general advice for it is you'll give analgesia as required. And warm compressing and warm showers are also advised on patients. And patients will also be advised to continue expressing milk because that helps with the mastitis. If they're systemically unwell or there's signs of skin cracking and nipple fissuring, then you can give flucloxacillin and antibiotics. Or, for example, if after 12 to 14 hours of conservative management, you can give flucloxacillin as well. And I think it's still okay for the I'm not sure, you may have to check, but I think actually I don't know what I say. But yeah, if any lactational abscesses form following mastitis, which is a potential complication, so basically where if there's, if you're not expressing the milk, and then it becomes infected and it forms an abscess and you get a lactational abscess, that requires antibiotics, anesthesia, and drainage, as would any abscesses do. So that concludes the entire talk. For the two people that are here, feel free to fill out the feedback form. Feel free to ask any questions as well. I'm happy to linger about for a bit. But yeah, that's it.